Okay, guys, peace, guys. If you see that I'm on Facebook Live, please, guys, let me know. Please admit if you can admit the candidate, that will be great as well. Let me, guys, check right now on the Facebook Live. Guys, am I live, guys, on the Facebook there? Let me double check. Yes, seems like I'm live on the Facebook. So, guys, I would love to check in on every one of you before we start. So, how is every one of you guys doing? I see them now, Dr. Natalie. Hi, Dr. Natalie, how you going? Let me share the screen right now. Please, admin, we have 6 champions and we have 8 champions in waiting room. If possible, please admit them. That would be great, Dr. Lara, okay? Okay. Okay, guys, I see you now on the Facebook, which I'm very happy to see all of you today. Hi, Dr. Natalie, how you going? Dr. Rana, how you going? Dr. Daniel, how you going? Hi, Dr. Nikita, how you going? Hello, Dr. Bidu, and everyone. Few days left. All the very best to everyone. Hope everybody succeed to achieve their dreams. God bless. Yes, I totally agree on this. And by the way, I pray to everyone. I pray, guys, to all of you. And by the way, today we have part 2 results. I believe we got 6 champions passed. Again, our leaders not just only part 1, our leaders also part 2. And by the way, guys, if you don't know who I am, my name is Adam. I'm a dentist, registered dentist in Australia. I've been work as a dentist for a long time, been teaching for ADC. I would say I'm the first tutor, I'm the first teacher used to start this journey to ADC candidates. I'm the one has made, I would say, the rest of other tutors to start the journey, because before me, there was no any tutors. So that's why I'm very proud with my leaders, either part 1 or part 2 champions. So Dr. Nikita, definitely, you're going to be one of the champions who has passed. I would say there are, by myself, I have had more than 10,000 candidates in this exam. So definitely you can pass the exam, Dr. Nikita, and every one of you. Hi, Dr. Sharma, how are you going? Dr. Eshika, how are you going? Dr. Shiva, how are you going? Dr. Shashank, how are you going? Dr. Rana, yes, they're doing great. Dr. Rana, keep revising. Dr. Fatima, and then Dr. Indra, Dr. Asanka, Dr. Kanika. Wow, that's 2 good names, Asanka and Kanika. Dr. Monisha, Dr. Vanik, and Dr. Vanik too. Dr. Monisha, Dr. Taslim, how are you going? Dr. Nikta, congratulations to all the past doctors. Yes, I'm very proud of them. They've been exactly like you. They have been in part 1. They doubted the journey, as every one of us doubted the journey. They've been under stress. They've been revising like you right now. And then they passed part 1 and they passed part 2. And now they're going to have completely different life. They're going to change. Their life going to be completely different once they get the registration. Hi, Dr. Dimple, Dr. Leo, Dr. Alifia, Dr. Simran, Dr. Muhammad, Dr. Leif, Dr. Teresa. Okay, guys, let's start right now. So everyone, guys, on Zoom, I see there is about 150 champions on Zoom. Please, guys, if you want to talk, if you want to answer the questions, you please jump into Facebook right now because we're going to discuss very important topics and concepts. Reading only not enough. Study only not enough for ADC. Reading books only not enough. You must have what we call it as critical thinking. Okay, guys? So now let's, guys, answer these questions together and see how we're gonna go with it. I'm sure, guys, you're gonna do the right things. Dr. Lev, we are proud of everyone in our family. Dr. Lev, big, big heart to you. That's a big heart to you for saying this. Dr. Mylene, how are you going, Dr. Mylene? Okay, guys, let's start. Again, we're going to only spend this time, we're going to spend maybe 40 seconds for everyone, guys, who's new, who doesn't know exactly what we're doing right now. These champions, they have exam next week, and we all support them to pass the exam, and we try to do our best to help them. So this is going to be very important. There are very important questions and very important concepts. So we put them a little bit under pressure for today to get the right concept and answer the question right way. Okay, guys, let's start right now. Let me get the paper first. Share screen. Guys, can you see my screen? By the way, guys, by the way, did you go... Okay, guys, 1 second, please, because I need to confirm this. Guys, did you go through Delicious? All the Delicious, guys? Guys, Delicious is easy, is the type of the notes. It's very easy notes. And then once you guys go through it, you will find things easy. So guys, okay, everyone say yes. It means like you really went through it. Delicious. I'm very happy. Please, guys, don't miss every single word in Delicious. Delicious, not like books. It doesn't have fillers in between. It doesn't have too much information knowledge. It's just direct on the point. Okay? Okay, I'm happy now. I've seen someone say something here. Why don't you lay you? It's just small. Please donate. Went through Bedu all? Okay, very good. All of them, I'm very good. Yes, going through, I'm very happy, guys. Let's now do it. First question, guys. The question is, a 34-year-old patient present with dull bilateral temporal headaches. Guys, once we say the word temporal headaches, what does it mean? What is the reason? It's mentioned the delicious. Bilateral temporal headaches. Is that something related to stress, for example? Hey guys, please, guys. Very good, paroxysm. I'm very happy. TMD, paroxysm. Very good. And headaches on walking, like when they woke up. And report that the jaws feels tired and tight in the morning, but improves during the day. So guys, what's the reason again? Muscle pain, muscle spasm. What's the reason? Grinding, paroxysm. Because paroxysm happened during sleep, right? That's why they have too much pain. Why they sleep once, just only they wake up. And then because in the morning they don't grind, things getting better. The patient reports rest in occupational stress. That's a reason. And the frequent intake of caffeinated drink. Caffeine, guys, does increase the stress. Clinical examination shows mild reduction mouth opening. What does it mean, trismus? Attributed to what? Muscle guarding. No joint noises are detected. There is no joint noises. Not severe cases then. It's just a muscle. No bone issue so far. Okay? It's outside. It's it's not inside, it's not around the jaw, it's not around the system, it's just a muscle. Good. There is occlusal wear facet. What does it mean? Grinding, praxis. Palpation of muscular muscles elicit discomfort. Now, which clinical observation would most strongly support the suspected diagnosis in this patient? Guys, you have only, guys, 40 seconds. Let me put the 40 seconds in my timer. Exam is soon. We need to learn time management, guys. Not just only reading. Yes, I put now 40 seconds. The answer is very good. If your answer right now is, because I'm going to say once the time's up. Okay, time's up. Answer is A. Reproducible tenderness and temporalis muscle associated with morning headache. Audible crepitus during mandibular translation. Look, this is severe cases. This means inside TMJ. Because guys, TMJ, look, TMD can happen for two main reasons. One, it is TMJ or muscle. So what has happened right now? Just muscle. It's not TMJ itself, not the joint itself, not the capsules, not the bone, not the condyle. That's what tenderness and temporalis muscle is enough. Audible crepitus happens because TMJ, because capsules, because arthritis, TMJ arthritis, which is not. So the answer is A alpha. Good in you. My champions always strong and smart. Question 2. Which factor below is most consistently associated with the development or persistence of patient's condition? Another 40 seconds. Guys, please, guys, very important to mark yourself. See which question you answered correct, which question you answered wrong, because this is going to be a good eye-opener to you for the next few days before the exam. Time's up. The answer is A alpha, psychological stress with altered sleep quality. Why this? Because we mentioned just a muscle issue. And when you have stress, guys, we always say stress is what? Stress is what? Devil, right, guys? Stress, devil. Stress, it can result in burning mouth syndrome. Stress can result in a high blood glucose level. Stress can result in grinding. Stress can result in low saliva and caries. Stress is a very bad thing. Major discrepancy between centric relation, centric occlusion. We have been knowing this. We know that 100%, no, it is actually 110% has been documented. What has been documented? That no relationship between malocclusion and what? TMJ disorder. Yes, there is no relationship between malocclusion and TMJ disorder. Do you know, guys, which case? The 1 million case. Guys, there was 1 million case. I don't think really I need to explain about it because I've explained about it before. After this, it has happened. It was a case in US, I think in 1995 or 94, 90 or yeah, maybe 95, 94, about a patient who has done orthodontic treatment by orthodontist, and then the orthodontist actually the patient ended up with a little of pain, and then the court has decided that the patient should get $1 million from the orthodontist because they thought malocclusion resulted in TMJ. After the patient died, because he got heart attack after he paid the $1 million, finally they found that there's no relationship between both. So guys, answer is A alpha. Please, admin, admit the candidates on the waiting room. Question 3. Removable appliances planned as a part of management. Which device is most appropriate in this patient? Time's up, guys. Answer is A alpha. Stabilization appliance providing full occlusal coverage. Why? Because again, the main issue is stress. The main issue is stress. So stress results in what? Result in grinding. Grinding result what? Extra forces on the muscle. I need to stop this. What should I do? I should do splint. What's the benefit of splint? Or how the splint gonna work? Splint gonna stabilize the condition by covering the full occlusal surface. When we do this, where the effect gonna happen? The effect will be on the muscle. What the muscle gonna happen? The muscle will be in rest. The muscle will have rest. If I put splint. Guys, what's the name of the splint, guys? Quickly, tell me what's the name of the splint. Is it soft or hard splint? It is hard splint. How we know it? How we name it? Michigan, right, guys? Like Michigan splint. Very good. So the answer is A alpha. If you answered correct, means you're great. By the way, guys, are you aware that we have a mock yesterday? Sorry, a mock yesterday. So guys, are you aware that we have a mock tomorrow? Yes, alpha mock, guys, tomorrow. Please, guys, be aware about this. Next question, question 4. You have only 20 seconds to answer it. Time management is very important. Time's up. The answer is as I explained. So what is the principal therapeutic effect of the appliance, of this appliance? What is this appliance? The splint. As I mentioned, the splint will result in redistribution of the occlusal forces with reduction in the elevator muscle activity. They go in to relax the muscle. Is it going to do anything on condyle? We said it's just a muscle issue. It's not a condyle issue. I don't want any effect on the condyle. Is it going to do something in this displacement? There is no displacement. It's just a muscle issue. It's not a TMJ disorder. It's not the capsules, not the disc, not the condyle, not the eminence. Nothing of these. Helping better sleep. Secondary, but this is primary. Elimination of occlusive discrepancies. We said there is no relation. Answer is A. Question 5. The answer is if patient reports acute muscular pain that interferes with jaw function despite behavior device, which pharmacological option is most appropriate initially? You know what? Paracetamol and ibuprofen. Why? Patient has pain. Give them paracetamol. Patient has inflammation. We need anti-inflammatory, ibuprofen. Do we really need to give them benzodiazepine now? No. Why? Why? Just start with the basic things, not benzodiazepine. We don't want to need muscle relaxant right now. We don't want to even to treat the stress by medicine. Maybe with some behavior management, things will be fine. So A alpha is the best. Could systemic corticosteroid hardly for a dentist to use systemic corticosteroids? Actually, we don't use systemic corticosteroids. Maybe topical, but not systemic. Opioids too much. Second scenario. A 28-year-old patient reports intermittent clicking from the right temporomandibular joint. The first one, the issue was what, guys? The first scenario, the issue was muscle. Now, look at this clicking start to happen. Do you think it's a muscle anymore? Do you think, guys, it's muscle? No, it's TMJ. So what is the issue right now? Capsules. That will be issue with capsules inside, not muscle. This is somehow more advanced stage. This is advanced now. Now, clicking has happened. Which internal joint disorder best explain this clinical presentation? What is a clinical presentation in this case? Let me tell you. What has happened is there is intermittent clicking. If there is a clicking happen, do you think there is reduction or without reduction? Guys, if there is clicking has happened, do you think the reduction without reduction? There is reduction has happened, right? Click means reduction. Okay, now, wide opening. Do you remember, guys, we mentioned that TMJ is like this. You're gonna have the crepitus, and then the eminence, and then the condyle, and then the capsules, right? Once the condyle moves here, guys, this is a mandible, okay? That's, guys, a mandible. What of the mandible? Once a condyle, this is a capsule or the disc. That's a disc. Once the condyle moves here, like now the patient start to open, 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 open. This was closing, this closing. Rest. Start to open, open, open. The condyle moves here now. This is the eminence. Now the capsule will stuck between the disc, between the eminence and here, and eminence and the condyle. If it does stuck, do you think the patient has opened the mouth completely or not? Do you think the patient has opened now? It's stuck here. The click will happen here. The click, because said, look, guys, at the key word here, opening widely, widely. Do you think when the patient open widely, is that early or delayed? Early when the rest. Early when just a little bit opening. Early when just open. But widely, start here. And then they're gonna close back again. Definitely late. not early. It's a late. Delayed. Now, the answer is anterior disk displacement. The disk has been moved because normally the disk should be here. Normally, the disk in healthy people, the disk should be at this area. Disk should be here, normally. But what has happened? The disk moved anterior, displaced anterior. So now, anterior disk displacement with delayed or error reduction, because we said reduction means click means reduction. Straight away, like this gun. This is gun, this gun. Okay? Myofascial pain means muscle only. Wrong. It's not muscle. It is capsules. It's a disc. So now what has happened is anterior disc displacement because the click has happened. Why it's delayed? Because the patient opened widely. That's it. Answer is A alpha. Guys, I have seen some of you mark B Bravo. Please, guys, if you mark B Bravo in the first instance, mark yourself down in this question, please, guys, because we need to know how many answers did you get it right. Question 2. Which additional finding would most strongly support this diagnosis? We mentioned there is a click has happened. Yes. Anterior disc displacement, it can happen with clicking or without clicking. Right? But if it's clicking has happened, right, that is a delayed issue. Intermittent locking. When you have only just intermittent locking, right, it means you still talking about the disc displacement with reduction. Progressive reduction in maximal mouth opening, no, 25 it's not. We should be less than this. Should be less than 25 to say it's a maximum mouth opening. No. Persistent deviation of the mandible. No, there is no deviation has been recorded. Cryptus during both opening and closing. No, only during opening. Been reproduced primarily on muscle palpation. No, it's primary on TMJ, on the disc. Answer is A alpha. Question 3. Which appliance may be used when the aim is to temporarily reposition the mandible? We need temporary reposition the mandible to facilitate disc recapture. Now, we need a little bit a device that is going to raise the bite a little bit and going to stabilize the whole situation. So what do you think the right answer then? I see you provided, guys, different answers. I see you between A and C. Guys, it's ambidextrous, guys. Should I show you in the ambidextrous? We need to stabilize the situation. We need to put back again to reposition back again the disc, the mandible to get the disc back again. Answer, guys, is C, Charlie, anterior reposition appliance. From the word reposition, because we need to reposition. That's a key word, okay? Okay. Answer is C, Charlie, anterior reposition appliance. Guys, we have delicious in every single appliance given to you. Please, guys, go and read it from there. Question 4. If the disc fails to reduce during opening and becomes permanently displaced, that's very bad. Which clinical pattern would most likely occur? "20 seconds only." Here, there will not be reduction. Will be without reduction. What does it mean? It means you will end up with limited opening with deviation toward the affected site. A alpha is the right answer. Because there will not be a balance. Guys, I know TMJ, very hard topic to understand. It's not easy, it's very complex. But that's why we try to simplify it as much as we can. Now, let's say if the disk fails to reduce during opening and becomes permanently displaced. You see, guys, the word reduce. What does it mean reduce? To going back. So do you think now we have a reduction or don't have a reduction? You can easily get it from the word this. Look at this word. Fails to reduce. So now let's learn this. You have eminence here. You have the fossa, and then the eminence, and then the condyle, and then the disk should be here, and then it became anterior displaced. The disk will be here, so there is no any more disk in this area. Now, if the disk fails to reduce back, so there is reduction, no reduction. So now we know it. If the patient cannot open the mouth because the disk will be here, how we call this one? No reduction. No reduction to the disk, to the capsule, to the disk. Okay? So this is a case right now. The patient cannot open the mouth because the disk stopped the condyle to move forward. Now will be no reduction to the disk. The patient will not be able to open the mouth. The patient will have bruxism. Trismus. The patient will have trismus. So this is gonna happen. Limited opening with deviation. Where about the mandible will be deviated? The affected side. Why? Because the other side is longer. When the other side is longer, the mandible will move toward the shorter side. So the mandible will move toward the shorter. Which one shorter? The one is affected. Answer is A. Question 5. Which conservative approach represents the most appropriate initial management? Is it a jaw rest with soft diet and avoidance of wide mouth opening? Okay, guys, 10 second times will be ending. Yes, that's what we want. A alpha. Just give a rest to the jaw. Things will be perfect. Just give a rest. And don't open the mouth too much in this case. How is it, guys, so far, guys? How are the questions so far? Easy question, not hard, right? Did you find it hard, guys? Our champions? Guys, it's a time management. That's why I'm going a little bit fast, because I want every one of you to ensure you got the right answer quickly, because the exam needs you to have a proper time management. Good, going good. I'm very happy. I'm very happy going good. Dr. Rahini and Dr. Bano. Easy. I'm very happy. You see now, Dr. Muhammad, everyone before used to tell me, Dr. Bido, we really, TMJ is very hard. TMJ is very hard. Now it's not hard anymore. The beginning of the course, everyone thinking TMJ is hard. Now everyone got the right answer. Not hard, Dr. Leah, right? Okay, let's go to the third scenario. A 50-year-old patient presents with persistent pain associated with the maxillary left first molar. Radiographic examination shows divergent roots. Okay. So the key words for me right now is divergent roots, close to the sinus, a little bit mobility. Oh, but there is tooth fracture has happened. Be careful from this. Okay, there is remaining root inside, retained roots. During irrigation of the socket, a small popping effect. Okay, popping effect is observed. Look, guys, listen, guys, this guys very carefully. During irrigation, small popping effect is absorbed. The patient reports sensation of air movement between the nose and the mouth. Question 1. During the initial extraction attempt, which factor is the most strongly justified starting with close extraction technique? There is one factor here going actually to make it decide, should I do surgical or non-surgical? Non-surgical mean closed. Surgical mean open. Guys, what do you think the right answer? Which tooth has, okay, the tooth has adequate mobility following initial, okay, A alpha, Dr. Natalie. Dr. Simran, A alpha. Dr. Taslim, A alpha. Dr. Muhammad, A alpha. Very good. A alpha. A alpha. Dr. Nikita, A alpha. Dr. Bano, A alpha. Dr. Melzman, Dr. A alpha. Dr. Pushpanda, A alpha. Everyone A alpha. B bravo. Only one B bravo. Dr. Amna. And Dr. Amna again B bravo. Now I have to stop. During the initial extraction attempt, guys, is this question for the whole molar or for the root? I think, guys, this is for the root. During initial extraction attempt, initial extraction for the root, right? Which factor most strongly justified starting with a closed extraction technique? Like, what things made me to extract the root with closed extraction? Is that because the root or the tooth has adequate mobility for initial laxation? The tooth is visible, or D or E? Okay, let's say this question about the root. Now the root broke. And then you need to decide, should you do closed extraction or open extraction? Closed means non-surgical, open means surgical for the root. What things here right now made you to decide either to do closed extraction or open extraction? In this case, if the root, so the answer C, Charlie, F for the root, right? So now, guys, let's learn this. If the question is all about the tooth, I will go with A alpha. But if it's about the root, I will go with C, Charlie. Okay, see, so we're gonna change this one, root, and this one, root. So now, if we're talking about the root, so the root is mobile or root is visible. Which one is more important? The root to be visible or the root to be mobile? The root to be visible. Now, if the root is visible, I can do non-surgical treatment. If the root not non-visible, in this case, I need to do surgical treatment or refer the patient to specialist. So answer to this question is A, but if it's for the root, so the answer should be C, Charlie. Question 2. When attempting to luxate retained root with a straight elevator, which technical principle most directly improves control and reduces slippage? "20 seconds, guys, gone." The answer is B, bravo. Using adjacent bone, a bone or tooth as a finger support during leverage. Why? Because we worried about the control and the slippage. To have proper control and to reduce slippage, you need to get support from the adjacent teeth or adjacent structure. B, bravo. Question 3. Because the root remains firmly embedded, what is the most appropriate next step? The root now, guys, is inside the bone and embedded too deep down. So what you need to do? Ten seconds left. Answer, guys, is B, bravo. 1. Increase apical pressure gently. We never increase apical pressure. Wrong. We don't put apical pressure. Create a precious point to allow control the engagement. Yes, we need to engage it nicely. And the best way to create precious point. Continue relaxation carefully. That's too much. You already have tried. There is no way. Don't try anymore. You need to try different ways. Don't do the same things again. Attempt removal using crier. Very aggressive. Abandon the extraction, prescribe antibiotics. Not in the first instance. Maybe at the end, I may refer the patient specialist and give antibiotics if there is infection. But I don't think there is infection in this case. So option E is wrong. Question 4. During irrigation, which finding would most strongly support the diagnosis of oral intercommunication? 20 seconds, guys, left for question 4. B, bravo. Passage of fluid between the oral cavity and nasal cavity. E, echo. Bubbling is observed within the mouth. So which one, guys? Visible root fragment of the socket. That's the third one, the delta. Visible root fragment in the socket. Someone answered A, alpha. Bleeding from the socket as well. Okay, guys, I see now the answer between mostly A and E. Dr. Monisha, for example, E echo. Dr. Simran, E echo. Dr. Seda, E echo. Dr. Semriti, E echo. Dr. Raza, B bravo. Dr. Jifa, E echo. Okay, guys, answer, guys, is B bravo. Passage of fluid between the oral cavity and nasal cavity. Why? Because read, guys, this option closely. It does say poppling is observed within the mouth. No, it should be within what? Within the socket. Wrong. Please, guys, in exam, believe me, this is the most important thing, to read things properly. I see Dr. Mylene, Dr. Leia, Dr. Nikita, Dr. Muhammad, Dr. Hira, Dr. Pushpenda. Answer the E echo. Bubbling will not happen in the mouth. Bubbling will happen in the socket. So B bravo, it does make more sense than E echo. Guys, where about the bubbling gonna happen? In the mouth or in the socket? Mouth or socket, guys? Please, guys, read the question properly. If you mark this question wrong, please write it down to yourself and say, I answered this question wrong. However, I start this topic. I know the topic very well. I know there is bubbling happening inside the socket. I know there is passage of fluid from the fluid from the nose sinus. The only thing that's made me not answer the question right is I didn't read the question properly or the options properly. I need only a few days left. I need to avoid this next time in the exam. If the communication is estimated to be approximately 1 to millimeter, what will you do next? If the you know what? ADC exam about these traps, guys. ADC exam about these traps. If you understand these traps, ADC exam will be easy for you. If the communication is estimated to be approximately 1 to millimeter, what will you do next? A alpha, immediate surgical closure. No, it's not. Someone answered A. B bravo, figure of 8 suture to stabilize screw. That can be correct. Someone mentioned D delta. Routine. No, we don't give antibiotics for this case. Maybe bigger can be antibiotics. Someone answer E. Ask the patient to bite on several layers of gauze or covering the area. Do next. No. E is not next. Why? What's guys wrong in E? You know, guys, what actually E can be correct, by the way. If ask the patient to bite right on a proper size of the gauze, will be fine. But several layers not good. We don't ask the patient to bite on several layers. Just a small piece of gauze. Not covering the area. Again, only covering the wound, not the whole area. So the answer, guys, B, bravo. Good job. All questions have traps. Same like EDC questions, by the way. Right? We need this. We need to learn this. A 52-year-old male presents complaining of increasing discomfort around the lower right posterior region for the past 4 days. Seems like we're talking about dry socket case. Okay, let's jump in the question. And then we can read the scenario back again. Now, which diagnosis is most consistent with the current clinical findings? No, actually, the patient has discomfort around the lower right posterior region past pain is dull. Dull means periodontal issue. The word dull means periodontal. Throat pain worsen with chewing, reports discomfort, sometimes radiates to the ear. Okay. Worsen chewing. Fracture restoration. Normal pocket depth means no periodontitis. Tooth is necrotic. There is periapical radiolucency. Okay. So now, guys, what is the most consistent with current clinical findings? Is it A or B or C or D? Patient has pain, right? And pain is dull, means acute. As the pain is, there is pain, so I choose a word acute. Chronic apical periodontitis, no, it's acute because there is pain. Reversible bites, no, reversible bites will only last, the pain will only last for a few seconds, not the whole day. Cracked tooth syndrome, severe pain, not dull pain, wrong. Occlusal trauma, completely distractor, A alpha. Question 2, clinical factor in the case most increases the risk of progression of odontogenic infection. Which clinical factor is the most increases the risk of progression of odontogenic infection? Diabetes. Patient has diabetes, guys. Right? If it's uncontrolled diabetes, it can result in infection. Be bravo. Question 3. If definitive treatment is planned, which option addresses the underlying cause most directly? My champion will answer this question. It's a very hard question, very tricky, but I'm sure you're going to answer it. If definitive treatment is planned, which option addresses the underlying cause most directly? RCT, because tooth is necrotic. Tooth is necrotic, right? See, Charlie, what do you think? Why, guys, you choosing why, guys, you choosing B Bravo? See, Charlie, please, guys, no B Bravo, okay? Because tooth is necrotic, guys. Don't give antibiotic. It's not an infection, just inflammation. Which imaging modality would be most appropriate if symptoms persist, but the pre-apical radiograph remains inconclusive? Seems like you already did X-ray before, right? And things didn't work. So we now need to have a better X-ray. CBCT. When you're stuck, take CBCT, because radiograph remains inconclusive. I need something to be conclusive. CBCT. The word inconclusive made two-dimension X-ray wrong. A two-dimension, not right. OPG two-dimension, not right. MRI, not necessary in this case. CBCT is the best. Question 5. Guys, do you know, guys, we have session at 8 o'clock? That's why I need to finish this paper quickly before 8 o'clock so we can start more questions. I mean, like more questions with question bank. Question 5. During interpretation of the radiographic taken in this case, which professional responsibility applies? Professional responsibility. Only going to evaluate the symptomatic tooth? No. Evaluate the entire radiograph. The entire radiograph. Everything in it. Not just only one area. What you see in radiograph, that's what you need to explain to the patient. Be bravo. Another scenario. A 30-year-old patient. Okay, guys, by the way, so far, how things guys going? Tell me, guys, how many correct answer you got? How many answer, guys? So far, we discussed about 20 questions. How many answer, guys, you got? How many correct answers? By the way, guys, we have our session. Tomorrow we have a mock exam, okay? Tomorrow we'll have a mock exam. The last, very, very, very important. Alpha mock exam. How many guys you got right? And for March candidates, all my prayers with you. And for September candidates, we starting nicely right now. So guys, don't be under stress. For September and March candidates, March 2027. Okay, next question, guys. Next scenario. What do you think the right answer? Wow, I'm very proud of you. 18, 18, 20. Wow. How come you scored 20? That's too much. I I wish, I pray to you, you get 20 in exam, you get 100%. 19, 17, very good. 17, very good. You guys doing really very good job. Okay, now, which explanation best accounts for the patient's cut symptoms? Is it localized infection? No, it's not localized infection. Dry socket, not localized infection. Is it disintegration or disturbance or premature loss of the blood clot? Yes. With delayed socket healing? Yes. Is it traumatic extraction? No. Is it remaining? All of this causes, like this can be risk factor, X factor, but the condition is B. B is the condition, but C and D and E, just risk factors. Question 2. So the right answer, guys, for question B, bravo. Which immediate management step is most appropriate? We need immediate management for dry socket. If you have dry socket, which one of this can be the best? Prescribe systemic painkiller. Is that good with dry socket? Should you prescribe painkiller? Curate the socket. Should you really curate the socket? Irrigate the socket gently with sterile saline. Should you really irrigate? Leave the socket undisturbed and review later. Do you think that's really correct? Suture in the socket. Do you think, guys, suture in the socket? Which one's the best here? The best C, Charlie. Guys, I'm very proud of you. I thought you're gonna choose A, alpha, or E, echo. I'm very proud. I see all of you guys choosing A, C, Charlie so far. Yes, guys, the answer is irrigate the socket. Do we really need to prescribe painkiller? Yes, but the question asked about, right, the immediate C, then A. C, then A. Answer, guys, C, Charlie. I'm very proud of you. During review, slow persistent bleeding continues from the socket. What is the most appropriate initial hemostatic measure? You need now to stop the bleeding. Dive pressure with gauze over the socket, or immediate ligation of the vessel, or systemic tranexamic acid administration, or hospital referral for surgical control, or packing the socket deeply into bone. Question 3 is, answer, guys, is A, alpha. Direct pressure with gauze over the socket. Immediate ligation of vessels, that's when. Guys, did you read this, guys, from Bedelicious, guys? Did you read all the stuff from Bedelicious? Please, guys, if you're still really not sure about the answer of these questions or the concept, please, guys, read Bedelicious. You'll find things very easy there. Very easy explained there. There is no hassle there at all. Answer A, alpha. Ligation, guys, we do for surgical when we really have a big cut in the vessel or severe bleeding. Systemic tranexamic acid shouldn't be systemic, should be local, topical, but not systemic. Hospital referral, not now. Packing the socket deeply, it shouldn't be deeply. So the answer A, alpha. If bleeding continues despite pressure and hemostatic packing, which step become most appropriate? Tomorrow we're gonna be the Alpha Mock, 8 p.m. Sydney time. Will be amazing. You will guys love it. It will be an eye opener. Question 4. If bleed continuous, guys, what you do? Discharge the patient, observe at home, wrong. Immediate antibiotic, wrong. Identification of bleeding point and ligation visible, yes. C. Charlie is the best here. Identification of the bleeding point and the ligation A visible. Question 5. If the patient later reports pain persisting beyond the 3 weeks with increase in swelling, which possibility should be reconsidered? If the patient later reports pain persisting beyond 3 weeks, means now it's not just a dry socket. It could be something more than this. And the swelling is increasing. For 3 weeks, that's too much. Normal post-operative inflammation, never. For 3 weeks, never. Persistent socket healing delay, could be. Mandibular osteomyelitis, not really. Not easy to diagnose mandibular osteomyelitis, but why not? Typical dry socket healing, no. Dry socket healing should be reduced. It should be that much bad, like shouldn't extend all this time. E-echo. So guys, what's the right answer here? I see most of you guys answer C, Charlie. Which is totally right. Mandibular osteomyelitis. Okay, guys, I'm very happy for September champions, September 2026 and March 2027. That was a quick online mock exam for our champions, March champions, just to test their knowledge and also put them in a little bit of pressure and stress, and also to have a proper time management. For all champions, our private champions, please guys, move now to the private link. Thank you very much, guys. We're gonna start our private Zoom link right now to go more with question bank and the more important questions and more concept. Thank you very much, guys. I was happy to have all of you here today on my page or our Facebook page. See you then next time. Most probably will be next week, early next week, or maybe tomorrow after tomorrow. We're gonna announce it. Thank you very much, guys. Our champions. Please, guys, let's move now to our private Zoom link. Thank you very much. Have a great night, every one of you. Thank you, guys. Bye-bye. Thank you, Dr. Rana. Dr. Hash, the answer is C, Charlie. Thank you, Dr. Rana. Thank you, Dr. Natalie. Thank you, Dr. Indra. Thank you, Dr. Musa. Thank you, every one of you guys. Thank you, Dr. Zina. Thank you, Dr. Asma. Thank you, Dr. Lev. Are you happy for March 2026? Definitely, I'm very happy. I see now, guys, your answer. This actually the topics is very hard topics and questions. They are very tricky, and then you did it very well. I hope, guys, you do the same in exam, and I'm sure you will do the same. Thank you very much, Dr. Shiva. Thank you, Dr. Tanvir. Thank you, Dr. Srisha. Thank you, Dr. Shiva, and everyone. Thank you very much. Okay, guys, let's now move to the private Zoom link, the private class. Thank you very much, you guys. Bye-bye. Thank you, Dr. Sapika and Dr. Lev, and every one of you guys. Thank you.